Every emergency assessment starts with the same foundation. BSI. Is my scene safe? Once the scene is secure, we look for the life threats. One of the most critical is S.H.O.C, or hypoperfusion. This is when the body's cells aren't getting enough oxygen. Identifying S.H.O.C. To identify S.H.O.C, look for the S.H.O.C acronym. S. Skin that is pale, cool, or clammy. H. Heart rate that is rapid. O. Ondansetron level nausea or vomiting. C. Changes in mental status like anxiety. K. Killing blood pressure, specifically a systolic BP below 90 millimeters of mercury, which is considered the threshold for decompensated shock. When we say a pulse is thready, we mean it feels like a thin, disappearing string under your fingers. It's fast, but so weak it's hard to count because the heart isn't pumping enough volume. The trauma scenario, rapid assessment. In trauma, we look for DCAP-BTLS. Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. You must check the head for Crepitus. This is a grinding or Rice Krispies crunching sensation you feel under the skin when broken bone ends rub together. Check the neck for JVD or tracheal deviation. Check the chest for equal rise and fall. Check the abdomen for rigidity or guarding. Check the pelvis. If it's unstable, do not touch it again. Finally, check the extremities for pulse, motor, and sensory function. If the patient is load and go, perform this exam in the back of the moving ambulance. The stroke scenario. Time is brain. When you suspect a stroke, think fast and focal. Use the Cincinnati Prehospital Stroke Scale. Facial droop. Have them smile. Does one side lag? Arm drift. Have them close their eyes and hold their arms out. Does one arm fall? Speech. Have them say, "You can't teach an old dog new tricks." Is it slurred or nonsensical? If any of these are abnormal, note the time last seen. Normal. This is the most important piece of information for the hospital. Transport to a designated stroke center immediately. If the heart rate is irregular, it feels like a drummer who can't keep a beat, stuttering or skipping, which is a major stroke risk factor. Respiratory distress sounds. In respiratory distress, the noises you hear tell the story. Wheezing is a high-pitched whistling, usually on exhalation, caused by narrowed lower airways. Stridor is a harsh, high-pitched crowing sound heard on inhalation, indicating an upper airway blockage. Rales sound like bubbling or popping, suggesting fluid in the lungs. The pediatric patient, the triangle. Kids are different. They compensate longer, but crash faster. Use the Pediatric Assessment Triangle before you ever touch the child. Appearance. Are they tracking you with their eyes, or are they limp? Work of breathing. Look for retractions or nasal flaring. Circulation. Look for mottling or cyanosis. If two sides of the triangle are broken, that child is in critical condition. Always remember to pad behind a child's shoulders to keep their airway open, as their large heads will naturally flex their neck forward. Final stabilization. Remember, your job is to find the red flags and provide stabilization. Treat shock by keeping the patient warm and supine. manage the airway for respiratory distress, and always alert the hospital early for a stroke. Precision in your assessment saves lives.